Thank you all. So it's pretty informal, so please feel free to ask questions at any time. I'm always informal, as hopefully my students know. So thank you very much for having me here. Just to give you guys a little bit of background, I know you're all thinking of either different fields or different ideas. Just to give you an idea of where I'm from for yourselves. So I'm from the Midwest. I grew up throughout since I was in kindergarten in Iowa. I went to Ames and then small college at Drake University and then finally University of Iowa. So all from the Midwest, finished my med school at Iowa. When I was in med school, I did a little bit of research, just to give you an idea. I wasn't very good at it, not that I'm any good now, but definitely wasn't very good at it then. I had great mentors. I think the only reason in medical school I did research, I loved my mentor, Dr. Ken Kimura, so I did a project with him. I also did another project. It was an educational project in med school. It was a simple project, but they paid me a small grant. My summer, I didn't have anything else to do, so I redid the neuroscience manual. So at that time, everything was in paper. Hopefully now everything's electronic, but everything was in paper. And so I worked with our course director to change that, update it, make it a little bit more multimedia at the time. That was in 1992, and that was kind of my introduction to education. My research project with Dr. Kimura was a retrospective project. We looked at Nissen fundoplication, so people that have real bad reflux, especially kids that have real bad reflux, they do a special procedure with their stomach, wrapping their stomach around their esophagus to prevent reflux. And they had done hundreds, probably one of the largest series at Iowa, hundreds of them as an open procedure. So like the old-fashioned way, you make a cut, you go inside, and you do it pretty nice. It's pretty fun, actually. Surgeons love to do stuff open. They're now doing all laparoscopic for patients, but in general, surgeons, I think, love doing open procedures. So they did hundreds of them, and then they switched to laparoscopic. And so we compared the two. Compared, complications, long-term outcomes, and I did a retrospective study, and if you guys any of you have done retrospective studies, now you know things hopefully are more electronic. Not then. I pulled every chart, 500 charts, 465 to be exact. I remember vividly, over hundreds of hours, over all my last year in med school, I pulled all these charts and did this, so I got to go present the abstract, which was great. It was an international symposium, but as my students know very well, I never published the paper. And so that was one of those things I always think about. When you've done a great project, you presented it, you got great feedback at an international symposium, just never close the loop to finish it. And so my students know how much I try to emphasize to them the importance of, if it's a good project, you got to publish it, otherwise you haven't finished what you started. So just to make a pitch for that right now. Currently we're at UC Irvine Medical Center, part of UCI. The main medical center, if you guys all don't know that, is in Irvine. It's not in Irvine, it's in Orange. So it's in UC Irvine Medical Center. If you haven't had a chance to be there, you should. Not as a patient, but as a researcher. Come and visit. And they do have some smaller clinics, medical buildings here. Most of the research actually happens here, interestingly, even though the med center's over there. And so currently I work as an emergency physician. I have an opportunity to work with our medical students in the medical school as the Associate Dean for Clinical Science Education. We have a small center, really small, Center for Trauma and Injury Prevention Research. It's more kind of a focus to bring folks together. We have some amazing collaborators that are very passionate about trying to decrease the burden of injury in the United States, and they're doing their part either through community outreach or through research or through actual health interventions at the bedside. And we'll talk about one of those health interventions, which is alcohol screening and brief intervention. I actually trained as a trauma surgeon, for what it's worth. So after med school, I went into surgery, and before finishing, I switched to emergency medicine. So that's kind of my passion for trauma, is my background. I saw for 3 years, every other night or every third night, I was on call and saw trauma patients in the hospital. And so we still see them, but I vividly remember seeing all of these car accidents and what happens, pedestrian accidents, whatever it might be. And then I currently work with our students. I've been a Bio 199 professor for many years. We have a group called Emergency Medicine Research Associate students that I've been the director, that now transitioning to another one of our faculty members. I've been working with Saeed and everybody in Europe. Our students have been extremely blessed to be part of the May Europe Symposium. Have been very fortunate to be recipients of the Europe grants, to be fortunate to have the opportunity to present their research in paper form in the UCI journal. There's just so many opportunities, I think, for undergrads, and both Helena and Kristen know from MRAP that how much I'm a proponent for. I'm just really try to push our students to do these kind of things, and and you can ask Helena, she'll tell you, I think SURFIT is extremely unique, even with all the other things I mentioned that's available at UCI, mainly because of what you see here. The attention they're giving you, the mentorship they're providing you, the collaboration you have among yourselves. I would just challenge you to really take maximum opportunity out of this summer, and Helena and Payan have both heard enough from me about this, so they know since last week that I was here how much I've talked to them about it. So let's get back to business, and this is logging off, but we will get back logged in when it gets a chance. So I want to talk to you guys a little bit about the use of technology that we do. I don't know if it ran out of battery.
No, it's plugged in.
Oh, it is. Okay, great. Maybe it just got tired.
Yeah.
Yeah, it looked like it was plugged in. I saw that too.
Yeah, the lights on.
Yeah, it's on and stuff.
I think it's just a phone management.
Oh, okay, no problem.
I'll see if I can.
So, no, that's okay. So, so what I'd like to talk to you guys about, I don't know if Kristen had a chance. Did you remember at all? Shucks, okay. Next time. So we'll have Helena bring them. So we have some brochures that we'll give you guys, either for the adult or the adolescent study that we're doing. So what you'll notice, we'll go through some of the more specifics when it's ready, but the main thing that we see a lot of is alcohol-related injury. And you see in college, people drink once in a while, hopefully not a lot. Unfortunately, when it comes to motor vehicle collisions, assaults, crime, pedestrian injuries, bicycle injuries, alcohol is a major player in the United States. We'll go through some of the specifics of what that is, but it is a humongous burden financially on our society, on you, on your future, and it affects our gross national product in the way that what percentage of it we're spending on alcohol-related injuries. We're not especially atypical for the world. It's not like we're by far the worst of all of them, but we have a society that places healthcare as one of its very important parts of what they do. And so when alcohol is a big part, it becomes a huge part of our healthcare expenditures. We're focusing mainly today on trauma, so traumatic injuries, but I can tell you, from those in healthcare, they can tell you this is just part of where alcohol comes in. So the other part that alcohol comes in is all the health effects. It affects your GI system that you guys have heard, liver, it affects your entire intestine. Cancer risk goes up from esophagus to stomach to anywhere in your intestine. It affects your body's function. It changes your immune status after a while. So there's humongous health effects all across, up and down the spectrum. So I'm mainly looking at it from a trauma perspective. We're the Center for Trauma and Injury Prevention Research. But when you look at it from a global perspective, it's really the medical health effects that affects people globally. That's really what it affects the most. So what we have been trying to do is, number one, quantify, looking at all the literature that's out there, the CDC, WHO, all of these, looking at how much of a problem it is in the United States when it comes, and what data do we have. We're pretty good. We're probably not as good as some of the European countries when it comes to data, or Australia is excellent when it comes to data. So we're not as good as they are when it comes to all forms of data, but we're, I think, really, really excellent. A lot of publicly available data that you can use. I would encourage you to become more familiar with that. But the other part of it is really, what can we do to make a difference? And that's what we're all about. We're trying to do. That's part of our emphasis in our center is, what health interventions can we do that will make a difference? So the part that we're looking at is screening and brief intervention for alcohol. So most of what people do when it comes to alcohol is they just screen. They look at, has the person drank? That's important to know. Have they been drinking? But they don't do much more. So it's probably updating. I bet you. Yeah. Oh, look, it's going kind of quickly. So, what most trauma centers do in the United States, most hospitals do in the United States, is they just quantitate the problem. They're like, this many people have alcohol, this is their alcohol level, and hopefully they go the next step, and I have some data to show you. Hopefully they go the next step to do something about it. So to have them meet with a social worker, have them meet with a nurse specialist, have them meet with a physician care provider to talk about, is this a problem for the individual? Obviously they were drinking. How much did it contribute to the injury that happened is always hard to know. If you ask the individuals, they'll usually tell you that's not the reason, obviously, for most of the reason. They would mostly say that, it was somebody else's fault, that's why they're there. And so, they were just minding their own business. And so, when it comes to alcohol, the alcohol level is not a very good screening tool, because all the alcohol level tells you is the acute level of injury. So all it tells you is they've been drinking now. It doesn't really give you any quantity of how often they drink. It doesn't give you any ideas of how much they need to drink. It doesn't give you any ideas of how it affects their life, their drinking patterns. It doesn't give you any of those quantities. So there's a nationally, actually a worldwide available product. It's called AUDIT, Alcohol Use Disorder Identification Test. It's a 10-question survey. It gives you more of a past history, more of a kind of historical view of how alcohol affects that individual. So we've used that. It's internationally, it's approved by the WHO, and that's what we've been using the most. The reason that we're doing our research, in addition to using AUDIT, it's a requirement by the American College of Surgeons to do alcohol screening on every single trauma patient that presents in the United States as a major trauma. So this is a new requirement. It's an important requirement. It's actually required for trauma center certification that you're doing this. The requirement is that most of your patients should get alcohol screening. We actually try to do a lot better than that, and our goal is 100%. Thank you very much. So just going through disclosures, none. I just have a small grant through the NIH. Other than that, no outside funding. So So the need in the emergency department are some of the things I've been telling you. I just view that there's a significant need in the emergency department when it comes, and I'll give you some reasons for it. The American College of Surgeons requires it, so they're the certifying body for trauma centers, and they require it. It's not easy to do. So the nurses want to help. The nurses are the individuals that probably spend the most time with the patients when it comes to healthcare. And they want to do this, and it would help if they had some other tools to use to be able to do this so it's not an additional burden on them. And I'll give you some ideas of why the computerized methodology might help in that respect. We have lots of data from UC Irvine to kind of talk about, and that's what we'll mention today. It's great for community outreach. When you go into the community to talk about it, it's good to have a tool to present to them. And we've been doing that through Clinic in the Park and Dr. Adrian. And it's changing. And this is just to give you some quantity of what's going on in the United States. So, alcohol use, it's one of the most important modifiable risk factors that we have. So 224 billion per year. So once you get into the B's, people lose perspective, but it's a lot of money. So $1.90 per drink sold in the United States. So I don't, some of you might have heard many years ago we tried to, not we, me, but California tried to place a $5, they called it nickel a drink tax. They tried to add a nickel a drink to pay for the healthcare costs of alcohol-related injuries, and it didn't pass. It had a strong lobby against it, and so just to give you an idea that the cost of alcohol-related injuries is much more than we can actually pay for in our system. So there's a huge prevalence when it comes to the ED. We often assume it. When somebody comes in with an acute injury, we just assume alcohol's been involved, either them or the person that injured them. It's one or the other. It's pretty rare that neither of them. So we just assume that that's the case. This is just relating to the National Highway Traffic Safety Administration, NHTSA. You might have heard quite a bit about them, that crash occurs every 2 minutes and a fatality every 31 minutes in the United States. And these are the high-profile things. The crashes and fatalities are high profile, but a lot of other injuries obviously are what really hurt people a lot more than these two. This is either drunk driving, pedestrian, or assaults. So just looking at the US as a whole, approximately a little less than 50% report that they abstain. Risky drinking, which is drinking that's higher than it should be, is about a third, 30%. Low risk drinking, which usually means that, so I'm assuming I should hit no.
Yeah.
Yeah. Came on earlier and I told it to postpone.
Okay. And then low risk drinking is people that are drinking, but they're drinking under safe guidelines, and dependent drinking is about 7%. So, and that matches what we have at UC Irvine approximately, and these are national data. Oh, there it is. So, so since 2007, the American College of Surgeons came out with this requirement. Every trauma patient needs to have this done, but so you need to identify them and the capacity to provide an intervention. And that's really what was not happening before. Then even today, that's not 100% in the US that this is happening for every trauma patient. I can tell you there are lots of emphases nationally for this to be not just for trauma patients, for all hospitalized potentially patients, all clinic patients, all healthcare encounters. So, some health systems are more advanced, they're much more aggressive about this. Some are just focusing on weight, some are just not just on weight, but on alcohol, which are two important preventable things, also on tobacco. And so this is one that really makes a huge difference. So just looking at the price tag for California, which is our little corner in the world. So the total economic cost is higher than this, but the latest was $38 billion annually. Again, billion with a B. So it roughly translates to $1,000 per California resident per year. $3,000 per family is the cost of alcohol-related injuries in California. So that in California is $280 per drink consumed. So pretty high. You can never really talk about alcohol abuse or alcohol use or alcohol disorders without talking about what is an actual drink. And that's part of the education we try to provide the patients, just so we have the same standard that we're evaluating everybody by. So beer, 12 ounces, liquor, 8 or 9 ounces, wine, even less, 5 ounces, and for shots, it's 1.5 ounces, which is a pretty small amount and usually not what people request. So the audit, what I was talking to you about, the alcohol use disorder identification test, has 3 categories: hazardous alcohol use, dependent symptoms, and harmful alcohol use. There's 10 questions total. The item, the content is like frequency, quantity, frequency of heavy drinking, and then for dependence, it's, you can't control, you don't have control over your drinking, morning drinking, guilt after drinking, blackout. So all these things that you might think of that might come up, these questions are all kind of contained all in a 10-item survey. Very quick, very easy to measure. The 2 areas that we try to focus on are not the dependent, and they're not the abstaining and safe drinking. We try to focus on the zone 2 and zone 3, which is the score for audit goes from 0 to 40. We try to focus on the 8 to 19 range, which is the simple advice or the simple advice plus counseling, and that's called the at-risk for drinking. So we don't focus on the dependent, which usually requires either outpatient treatment or inpatient treatment. We do have a simple card that kind of reminds people about what is safe drinking. Men, it's at-risk drinking is greater than 14 or 4. Women, it's 7 and 3. 65 and older, it's 7 and 3 per week. You might think 3 drinks at any day or any time is too many. That's actually the standard. So seems like a lot to me. I don't think most people have 3 drinks in a day, but they probably do. If 50% of the people are, could be up to 50% could be drinking a little bit more than they should. So I want to just focus on our thing, which is alcohol screening, brief intervention, referral to treatment, or as you might have heard, SBIRT is what they say. They found that it's helpful, effective. They found that the emergency department can be a teachable moment. So people come to the emergency department usually not willingly. Usually they're not happy about it, but they need to come to the emergency department. So, potentially that can be a teachable moment to talk to them about how alcohol could be affecting this visit. And this is not just for trauma, it's for medical reasons. And they found that it's quite useful to try to combine that teachable moment with their. So then just looking at early intervention for either at-risk or dependent drinkers, they found that it, high-risk and dependent drinking reduces the quality of life for people, just as you probably anticipate, and it costs not just them, but society. We talked about some of the society stuff. This medical encounter, either the ED or someplace else, it's an important event that normally people take pretty seriously, and it's an important opportunity we can use to, give them some teaching, some feedback. It usually, and they've looked at this many of times, a physician or healthcare provider feedback and advice can be a very powerful motivator for change in them. The intervention that we do can have important prognostic changes in the person and of their behavior, and they have shown that it decreases ED utilization and cost, which is one of the important reasons we're doing this. But they found that this kind of brief intervention, SBIRT, can reduce alcohol use for even up to 12 months, one single encounter can reduce it at times up to 12 months. Probably the interventions they're talking about are a little longer than what we're doing. That's why we're looking at the effects of what we're doing and how effective they are. There's a similar effect size they've seen in previous studies for men and women. Decreases sick days to work, decreases drinking and driving, decreases scores on alcohol-related problems following that. So just at UCI, we've been doing this since 2006. Dr. Vaca was here previously. He's now at Yale. He started this with his team, Diane Nguyen, Dr. Craig Anderson, who's still with us. It's both English and Spanish. It's just touchscreen. We've kind of revised it a little bit, but our focus has been to try to provide it to as many folks as possible. It's bilingual, English and Spanish. And it's a motivational interview. So you'll often hear when it comes to behavioral intervention, they're trying to do a motivational interview. And I'll tell you a little bit about it, but really what it boils down to for a motivational interview is using the patient's own motivations, the individual's own motivations to change behavior. So instead of me coming to you and saying, oh, I think you got to do this, this, and this, and this, you say, well, how's this affecting you? You're like, well, it's bothering me in these ways. Well, what do you think? How do you want to go about? Do you want to change? Do you not want to change? Do you want to even talk about it? Yeah, I want to talk about it. So you just kind of go down this path. You can imagine with an individual that would take some time. We've kind of streamlined it with the computer so it doesn't take that long. It's all computer-based from beginning to end. Just looking at the evolution of CASI, so it started 2006 and this big computer system with this big battery system. Then it went to kind of the more sleek look, and then it went to the complete weight loss module here. So we went to the tablet module, so it's the least weight. Even, obviously, you've seen thinner tablets than this. The main reason we use this tablet is you can clean it, you can even dip it in solution, and it's okay in a hospital environment. Most other tablets, you can't clean them with a cloth, otherwise the whole thing stops. So our screens are pretty simple. We haven't had a lot of resources except for the research aspects to really change it around. But we ask the questions, all the alcohol use disorder questions. But we try to ask them specific questions. That this is the motivational part. So this is one of the questions. So you reported you have this many drinks. You reported that this many drinks a month, this many drinks at a time. This drinking increases your risk of injury and having problems. The recommendations are no more than 4 drinks, no more than 14. So we keep re-emphasizing this through them. But what we're using throughout the module is really their own answers. So here's a typical question that we would ask. We suggest you take a moment to think about it. And the information you've received, which of the following? Are you willing to cut down on the amount of alcohol you drink? I commit to no more than 4 drinks and no more than 14. I commit to quit drinking. So we ask them whichever one you want, and then we use their answers to go down a different pathway with CASI. You could do this with any behavioral intervention. It obviously doesn't have to be just alcohol. And then we give them a printout at the end that kind of summarizes everything. We give them informational handouts. And through our research study, we're trying to follow them up to see if it's made a difference. So one of the main questions that always comes up to us is how long does it take? Obviously people are busy. We don't want to interfere with their care. And so, for the people that never drink, for the ones that never drink, both the questions and the information, 2 minutes. For the within recommended levels, 3 minutes. At risk, 7 minutes. Dependent, again, 7 minutes. So not a lot of time. Most of the brief intervention research takes a lot longer than this. The SBIRT research that they've done, both with a person and with other modules. So ours is, you could say, super brief intervention compared to what's out there in the literature. So how are we doing this? We're doing it at UCI in the emergency department. We're doing it at the trauma center. We're doing it through Western Medical Center. We've made it available to them. But more successful than Western has been Mission Hospital through nurses and social workers, UC Irvine Outreach Clinic through nursing students, and we also have Kern and Stanford are using it, and we're also starting to implement it in Puerto Rico. The At the medical center, it's with research students that it's been implemented. So instead of having every time for a nurse to take the tablet to a bedside, we have a researcher that takes it to the bedside and does it. They've been fairly successful when it comes to just trauma patients. Just to give you some results of how successful we've been. So this is kind of one of the things that's really critical when it comes to alcohol, is you want to be able to pick up as much of the patients telling you they're drinking as you possibly can. So we compared to what Cassie, which is our computerized program, picked up from the patients on drinking to what they reported when they presented to the emergency department, to nursing. So we compared that. We had the data when they presented to nursing, they wrote it down, and then we had the Cassie data that immediately that same patient would fill out. So the first one was verbal to the nurse when they presented, the second one was on a computer by themselves, nobody around them. So Cassie showed increased detection of alcohol consumption and at-risk drinking. This was self-report over the MSc, which is the nursing medical screening exam, across all ages, gender, and language. So just to show you the effects is, so this first one is abstinent. So with Cassie, it went down, statistically significant. So drinking not at risk went up, drinking at risk went up. If you even want to break it down even further, every one of these bars are statistically significant in every age group, from from basically young adult all the way to older adult, male, female, gender, and as well as ethnicity, English and Spanish. Everybody's statistically significant. So another paper that was published by Dr. Baca before was just looking at the feasibility of doing this. This was one of the earlier papers. So a higher percentage of young patients, males, screened at risk or dependent. That's not unusual. That's what we see no matter who talks to them. But this corroborated what happens in the literature and what happens in real life. But this was the reason we did it. Patient surveys indicated Cassie was easy to use, and over 75% did not prefer a medical professional over the computer. Which is really the bottom line is, we're happy to do what the patients want, and they said, we kind of like it. Why change? So the other thing we looked at is, so this was a 6-month follow-up. So we compared, for this specific study, we compared Cassie to itself. And so for the patients that received Cassie only, they had greater reduction when compared to itself on follow-up. Their readiness to change was a good predictor of drinking below the recommended limit. So if they were really ready to change, and that they reported, we didn't tell them, they reported, I'm ready to change, that was a good sign that there's a good chance they might stop or cut down on drinking, which makes sense, right? If people are not ready to change, no matter what you tell them, unless the penalties are so high, even with all the penalties in our system, you see we still have more prisoners than we should. So using computerized SBIRT with integrated personal messaging and BNI holds promise, which is really providing them information, providing them personal feedback is hopefully helpful. This was another study we did, assessment of readiness to change in relationship to auto-score in trauma population using computerized alcohol screening and brief intervention. This was, we saw that 25% of the 1,145, which were consecutive trauma patients, drank more than recommended, and 4% were dependent. And they're driving. And they're driving. They're drinking more than they should, and they're dependent. And these are trauma patients to a major trauma center. And this is self-report. This is the patients reporting to you. You can only imagine it's higher than that. Not going to be lower than that. Right? Nobody on an anonymous survey thinks that they're going to take credit for something they're not. We told them right from the beginning. So half of the patients who drank more than recommended rated themselves on a 10-point scale, 8 or higher, that they're willing to change. So they're looking for help. They're open to it. They want to at least. They're willing to consider it. There was no downside for them saying, I'm not ready to change. They could say it. That's okay. But this was the other part. We always keep asking this just because we want to know if people don't like it. 92% of trauma patients found CASI easy to use. 87% were comfortable using it. So this is also found in the literature. Spanish-speaking males have had the highest audit scores of females, white females. Spanish-speaking males exhibited the highest frequency of drinking per week and day and least willing to change. So this is important as we're trying to roll out interventions potentially, especially in California with almost 50% Hispanic. So more alcohol screening brief intervention should be available. Absolutely. I mean, we need to have more and more of this. Otherwise, you know, what we're spending on healthcare costs, we're going to continue to spend, if not increase in the future. So some of the lessons learned, you know, so far, it's not done. CASI seems to be effective. So far, it's been well received. Provides an important service to patients. At least that's what our trauma center feels. And it requires a level of commitment to do this. We do it with research students, but other places do it with nursing, and they're very effective. CASI can definitely defray costs if you wanted to. We don't bill for it at UCI, but there's a billing that's available. Always important to know that there is a way to compensate for some of the costs. It's definitely easy to maintain as long as the computer system doesn't go down, our program doesn't go down. We went down this weekend because our entire computer system went down, not because CASI went down. It's a pretty well-functioning program by itself. We do lots of community activities. It's great to reach out to the community. We're fortunate to have students. This is the fatal vision goggles that you might have seen people wear to simulate different alcohol levels. We should have brought them next time. Just so people can walk a line and see what the different alcohol levels do for you. And then we have lots of different outreach events that we try to participate either through UCI or the community or other places. I really think you might not be surprised to see this, but it would have been surprised a few years ago. Portable devices are really the way this is going to go. You know, the more information we can make at people's hands, the higher likelihood we are to make it interesting and available to them and viable to them. And so we're obviously making it more mobile as much as we can. But I'm open for questions, especially from our students.
Thank you.
So.